Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Lindsay Smith-Rogers. Today, outbreaks of measles in the United States, including in the state of Florida, where reports indicate that the state's Surgeon General may be turning away from standard outbreak control measures. Dr. Saad Omer is a vaccination expert and the founding dean of the O'Donnell School of Public Health at UT Southwestern in Dallas. He speaks to Dr. Josh Sharfstein about how to keep measles outbreaks from turning into a measles wildfire. Let's listen.
Dr. Saad Omer, thank you so much for joining me to talk about some of the latest developments on measles. And I'd like to start just with a refresher about the measles virus and why it is so dangerous.
Well, measles virus is particularly dangerous for two reasons. First of all, it's one of the most infectious common viruses that is out there, especially a virus that impacts children. So you catch it very easily if there is any lapse in immunity in the population. The second reason is that it not only causes an acute illness, it has an impact on your immune system that lasts for a few years. And so it makes, especially children, but others as well, more vulnerable to other infections. So it has this 1-2 punch that it strikes with. That's why a lot of us pay attention when cases start emerging.
We haven't had that many cases in the United States, but measles is more common around the world and causes quite a lot of harm.
It does. And it's a very unforgiving virus, especially in public health emergencies. If there is a lapse in the high immunization coverage that is needed to keep this virus under check. So therefore, I think we need to pay attention to the cases of this virus. I'll give you an example. During the Ebola outbreak, the substantial impact, and in fact, there was a higher impact of measles virus on children in terms of disease and death than Ebola itself, because Ebola in West Africa a few years ago resulted in interruption of the immunization system.
We're talking about cases of pneumonia, meningitis, other complications. Measles claims more than 100,000 lives a year still.
Yeah. And for a while, we thought that we're going to get it more under control, but that hasn't happened. It is a sad situation. During the pandemic, globally, there was a major setback, especially for measles, but for other diseases when the routine immunization coverage dropped. We started seeing these outbreaks around the world, especially in low and middle income countries, but not exclusively so. There are other places where measles is showing up, including places like Europe and now in America.
So let's talk about America. We have more than 25 cases already this year in the United States, and we have pockets of the population that are vulnerable.
Yeah. And you used a very important word in this, pockets, because sometimes we become complacent when the average coverage of, let's say, a state or a country or even a county is okay, above the so-called herd immunity threshold. But diseases transmit very locally. And so when you have these clusters of vulnerability, and we have actually studied that in multiple locations using spatial epidemiology, spatial as in space, as in geography methods, to say that, the local clustering is very important for transmission of these diseases. So this is what we are seeing. In the US, there are many places where these local pockets of vulnerability.
Let's talk about what can happen. A case, comes in maybe from one of these other countries where there are many, many cases. Someone contracts it through travel, shows up at school, for example. What's the risk?
Well, the risk is to start an outbreak. And vaccines are really good, but they are not perfect. So typically what happens is, and what has been happening since we eliminated the indigenous transmission of measles by the year 2000. And so a typical pattern is that an American family goes overseas and has some people who are unvaccinated, brings back the infection, and then goes to school or a clustered population or a dense population situation. And there is a little bit more vulnerability. There are a few more kids who are unvaccinated. And then it starts an outbreak. And so we did a review, we did a study to see that actually unvaccinated people are overrepresented in early parts of these outbreaks. When then there is this fire that spreads, think of like dry tinder, and sometimes it consumes wet wood as well. Because, again, vaccines are really good, measles vaccines are really good, but when there is a lot of virus around, they're not perfect. And so it spreads to a broader population. Often it results in schools getting shut down. And if that doesn't happen, then you start seeing all sorts of second order effects. One thing I would point out, if I may, when we talk about importation of measles, there's this perception that it is coming from countries that are somewhat less developed than us. We actually did a study on that. We found that if you account for immigration, legal or otherwise, because a lot of folks who come through that pathway come from Latin America and other places, and these countries have a higher immunization rate than the United States, importation of cases is not happening from here. Compared to places like France, etc., and all sorts of other countries where Americans tend to go more, that's where the importation is coming from. And so that's a nuance to keep in mind when we talk about importation of measles.
I appreciate your mentioning that because there could be misunderstanding. People can go to Europe, pick up measles, bring it back, infect the community. Let's just talk for a second about what happens in a community when you have an outbreak. What do you have to do to stop it?
First of all, you get the immunization rate up. So the only way to control an outbreak is to get ahead of it. So the first step is a good, solid outbreak investigation. And some measures. So unfortunately, schools, this is not an ideal situation. Unfortunately, schools, but individual schools, not at a mass level, have to at least transiently send kids back home because there is substantial vulnerability of everyone, including those who have a weaker immune system, but it increases the general vulnerability of children in that place. But then good outbreak investigation in getting the immunization rates up and sort of following the isolation protocols for those who are actively infected. So these are the sort of the meat and potatoes strategies of public health to control the outbreak. And so we can do that and continue to respond to as these fires flare up, but the long-term sustainable strategy is to keep the immunization rates up.
So just to drill in a little bit on the response, there's a child, maybe they went to Europe, they come back, they have measles, they've got to stay home and isolated. What about kids that they've exposed in class?
Yeah, again, depending on the level of exposure and whether, it was an exposure in certain cases, jurisdictions decide to send them home or send the class home or sometimes more drastic. So that depends on the situation.
So typically there's an investigation, and based on the nature of the exposure, whether the child had the rash when they were near other kids, and that determines when kids need to be sent home. And the reason I'm asking all of these questions is because we're now getting word out of Florida that the state is not following the usual protocols for responding to a measles outbreak.
Yeah, so with Florida, what we are getting is news reports. So it's hard to say. I'm waiting for an actual scientific report to come out to see the actual situation. And so I'm hoping there will be an MMWR, morbidity and mortality weekly report. Sometimes things that are reported in the press are not exactly the full picture. But broadly speaking, I think in this country, the success we don't talk about often enough is the elimination of indigenous transmission of measles in this country. That was a major success led by states, led by the CDC that has happened. And so it would be a tragedy if there is a breakdown of that success.
I guess let's just say that what we're hearing right now is the case and that standard public health precautions are not being followed in a school. And what you wind up with are kids who would ordinarily be told they need to stay at home to make sure that they don't develop measles, but in fact, they're in school. What is the potential risk of that?
The potential risk is the virus spreading well beyond a specific area. We are a connected country, and there are other pockets of vulnerability that are out there. And we also showed in a separate study that there is a pocket of vulnerability in infancy as well, in early toddler age, because we vaccinate in this country at 12 to 15 months, and we give a couple of doses in that year. And not everyone is protected through maternal antibodies before that. We have decided as a country that the sweet spot is when most of the maternal antibodies wear off. So there is multiple ways of those pockets of vulnerability to emerge. And so it is unfortunate if an outbreak is not controlled. Look, it's like a wildfire. If you go after the ambers, you prevent the risk of a wildfire. It is a lot costlier, it's a lot more tragic and more impactful to control a wildfire than to douse the embers.
Now, we can already start to see that this is being viewed by some as just an issue for parents to decide for their own kids. And that, look, if you want your kids to get vaccinated against measles, go for it. If not, that's your call. Also, I wonder if you could talk about what that leaves out, because you're talking about the particularly vulnerable groups if there is a wildfire. Are you saying that there are kids who are too young to get vaccinated who might be at risk? And what about kids with chronic illnesses? How does that play out?
So look, I grew up under a dictatorship for a lot of my childhood. So I take questions of personal autonomy very seriously. And I do think that in a lot of these situations, parents and individuals should have autonomy and they get to decide about what's best for them and what's best for their children. But then in case of infectious diseases, so infectious diseases are just that, they're infectious. And in these situations, because they transmit from one person to another, a few parents are then deciding for the rest of us. And the rest of us include children who are too young to be vaccinated. They include children who have other immune system issues or other sort of illnesses that make them vulnerable, but also, children who are otherwise healthy. Again, vaccines are really good. They're not perfect. And they are made vulnerable through exposure. And so therefore, it's okay to decide for your own child, but please don't decide for my child.
What I hear you saying is that it's not at all so simple as every parent gets to decide for themselves, that there really is a social choice that has to be made about whether we're going to be in a world with a lot of measles or we're going to be in a world with essentially no measles.
That's unfortunately true. In case of infectious diseases, that is actually very true. We need not only high level of vaccination coverage when it comes to measles, we need very high level of vaccination coverage. And so it's not just that other people are deciding for the rest of us, it's only a few people that get to decide for most of us. Herein lies the issue that you have zeroed in on.
One last question for you, Dr. Omar. I know you've thought a lot about misinformation and the challenge of social media. How do you see this playing into the coming battle against measles in the United States?
Look, we know that from several studies that we and others have done that healthcare providers are the most trusted source of vaccine information. And so therefore, we should leverage the evidence base that has developed around communication science to create a national CME, continued medical education program, so that healthcare workers have the tools to talk about or communicate, not just talk in the clinic and in communities around vaccines. That's number one. Number two is that right now, if a practice administers vaccines, there are ways of paying for the vaccine and vaccination, but you don't know that until someone has made the decision. So we need to make counseling for vaccination in and of itself a reimbursable act. So those things will move the needle on all sorts of issues around communications, that healthcare providers remain the most trusted source of vaccine information.
Well, I think that's what we want to do with vaccination, is move the needle. And it sounds like when you are able to train clinicians, that is essentially a bulwark against the information that people may be getting off their apps or in group chats when they actually have a trusted healthcare provider who can talk to them.
Yeah.
Well, Dr. Omer, thank you so much for joining me on short notice to talk about this urgent situation. We hope that 2024 is not the year of measles in the United States, and we'll keep in touch with you.
Fingers crossed. Thanks.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Grace Ceciri. Audio production by J.B. Arbogast, Holly Cardinale, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Ceciri and Eliza Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.